This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System titled, "To Improve is to Change, but Is It Safe? A Single Surgeon's Transition from Lateral to Vertical Hemispherotomy."
It's a provocative title, Alara. It's a quote often attributed to Winston Churchill, but in the context of pediatric epilepsy surgery, it carries a lot of weight. We're talking about hemispherotomy, which is a cornerstone treatment for children with drug-resistant epilepsy, or DRE.
Exactly. And as we know, about 1 in 3 children with epilepsy will become refractory to anti-seizure medications. DRE isn't just about the seizures themselves. It increases the risk of cognitive and developmental regression, a poorer quality of life, and even early mortality.
Right. We see this often in cases with hemispheric abnormalities, things like congenital lesions, such as diffuse cortical dysplasia or hemimegalencephaly, progressive disorders like Sturge-Weber syndrome or Rasmussen's encephalitis, or acquired insults like perinatal stroke.
The paper provides a nice historical context, too. It mentions Mackenzie's first case report of anatomical hemispherectomy in 1938 and Crenow's case series in 1950. But modern practice has shifted toward hemispherotomy, functionally isolating the hemisphere by transecting commissural fibers and projections, while minimizing actual cortical resection.
And that brings us to the core of this paper, the technique. For years, the lateral perisylvian or transsylvian approach has been the established, widely practiced standard, but more recently, the vertical parasagittal method has gained traction. Alara, for our residents listening, can you walk through the anatomical differences described in the paper?
Of course. The paper actually includes a great diagrammatic representation. In the lateral perisylvian approach, you're looking at a suprasylvian disconnection, an insular undercut, an infrasylvian disconnection, a temporal disconnection, and a corpus callosotomy. It's very much a lateral to medial progression.
And the vertical?
The vertical parasagittal approach is different. It involves using a superior frontal gyrus window to enter the ventricle. From there, you perform the corpus callosotomy, the insular undercut, and the temporal disconnection.
So the big question this study asks is, if you are an experienced surgeon who is a master of the lateral approach, can you safely switch to the vertical approach? Or does the learning curve put the patient at risk?
That's the crux of it. The study followed a single experienced epilepsy surgeon over a 9-year period, from 2016 to 2025. They looked at 36 patients, 23 underwent the lateral perisylvian approach, and 13 underwent the vertical parasagittal approach.
I think it's important to mention why a surgeon would even want to change. The authors cite a post-hoc analysis of the original HOP study, the Hemispherectomy Outcome Prediction Scale, by Falah et al. That study suggested the vertical method might actually produce significantly better long-term seizure freedom rates.
Plus, there's the morbidity factor. The vertical approach is thought to require less cortical resection and less operative time, which should theoretically lead to fewer blood transfusions and complications.
So let's look at the data. Did the transition work? Was it safe?
The results are quite compelling. First, let's talk about seizure freedom. At the 1-year follow-up, 90.9% of the lateral group were seizure-free. That's angle class 1. In the vertical group, it was 83.3%. Statistically, there was no significant difference there, with a p-value of 0.602.
That's a critical point for residents to grasp. Even during the transition to a new technique, the primary goal, seizure freedom, wasn't compromised. But where the vertical approach really seemed to shine was in the perioperative metrics, right?
Absolutely. This is where the efficiency of the vertical approach became clear. The mean operative duration for the vertical group was 340.9 minutes. Compare that to 448.8 minutes for the lateral group. That's over a 100-minute difference, and it was statistically significant with a p-value of 0.002.
And what about blood loss? In pediatric neurosurgery, especially with these large disconnections, hemodynamic stability is everything.
The data backed that up too. The intraoperative hemoglobin drop was significantly less in the vertical group, 18.1 grams per liter, compared to 27.2 grams per liter in the lateral group. Again, a p-value of 0.002. However, despite these intraoperative gains, the mean hospital stay was basically the same for both, about 8.7 to 9.8 days.
It's interesting that the hospital stay didn't decrease despite the faster surgery and less blood loss. It suggests that the post-operative recovery for these kids is perhaps more dependent on the brain's reaction to the disconnection itself rather than the specific surgical route taken.
That's a great point, Dr. Aris. Now, I want to dive a bit deeper into how the authors accounted for the learning curve. They didn't just compare the two groups. They split the patients into chronological epochs.
Right. They used a binary logistic regression model to see if the time or the epoch affected seizure freedom while controlling for the Hops variables.
For our listeners, let's quickly recap those Hops variables mentioned in the paper. These are the 5 independent predictors of seizure freedom: age older than 3.5 years at seizure commencement, stroke as the etiology, no previous resective surgery, absence of generalized seizure symptomology, and absence of contralateral hypometabolism on FDG PET.
And what did the epoch analysis show?
It showed no statistically significant difference in 1-year seizure freedom across the chronological epochs. The p-value was 0.816. This suggests that the surgeon's transition was safe from the very start of the shift in technique. They didn't see a dip in success rates while the surgeon was getting used to the vertical approach.
That's a very reassuring finding for senior surgeons who might be hesitant to adopt newer techniques. It shows that an experienced epilepsy surgeon, someone who already has a sound grasp of the 3-dimensional anatomy of the ventricles and the corpus callosum, can translate those skills.
The authors do note that while larger studies might eventually show one technique is superior to the other, it's useful for a surgeon to have both in their armamentarium.
Exactly. Not every patient has the same anatomy. If you have a patient with specific distorted anatomy, one approach might be safer than the other. Having both techniques allows for a more tailored approach.
We should also mention complications. The paper states there were no statistically significant differences in complication rates between the two groups. Hemispherotomy always carries risks, but switching to vertical didn't incur additional morbidity in this series.
It's a small study, 36 patients total, but the single surgeon design is actually a strength here because it eliminates the variable of different surgical skill levels. It really isolates the technique and the transition itself.
So, to summarize the findings for the residents, the vertical approach was faster and resulted in less blood loss, but the seizure freedom rates and hospital stays were comparable to the lateral approach. Most importantly, the transition didn't lead to a danger period for the patients.
It goes back to that quote, "To improve is to change." The surgeon in this study changed their approach to something potentially more efficient, and they did so without compromising safety.
It's a great example of how even experienced attendees continue to evolve their practice based on emerging literature, like the Hops study.
Well, that's all the time we have for today. Elara, thank you for breaking down the data.
My pleasure, Dr. Aris.
And to our listeners, residents, and colleagues, remember that while the lateral approach is a tried and true workhorse, the vertical approach is a powerful tool to have in your surgical kit. We'll see you next time on the Neurosurgery Hub podcast.
Goodbye, everyone.